Welcome back to the channel where we break down complex medical topics into clear, clinical insights. Today we're diving deep into SSA and SSB antibodies, also known as anti-Ro and anti-La. We'll explore their immunologic targets, disease associations, diagnostic value, and practical implications, especially in autoimmune and rheumatologic care. Let's get started. SSA and SSB are autoantibodies targeting specific ribonucleoproteins involved in RNA processing. They're part of the extractable nuclear antigen panel and are highly relevant in systemic autoimmune diseases, particularly Sjogren's syndrome and systemic lupus erythematosus. SSA targets two main proteins, Ro52 and Ro60. Ro60 binds misfolded RNA. Ro52 is an E3 ubiquitin ligase with a role in regulating innate immunity. SSB targets a protein that binds newly synthesized RNA polymerase III transcripts, stabilizing them and facilitating RNA maturation. These targets are intracellular proteins, typically hidden unless apoptosis or cellular stress occurs. SSA and SSB antibodies are most diagnostically useful in Sjogren's syndrome. SSA is present in 70 to 90% of primary Sjogren's cases. SSB is seen in 40 to 60%, but rarely without SSA. Their presence correlates with dry eyes and mouth, parotid gland swelling, and systemic complications like interstitial lung disease, vasculitis, and renal tubular acidosis. In systemic lupus erythematosus, SSA is found in 30 to 40% of patients. It's associated with photosensitivity, subacute cutaneous lupus, leukopenia, and serositis. SSB is less common in lupus and rarely occurs without SSA. SSA and SSB antibodies can cross the placenta, leading to neonatal lupus. This can cause congenital complete heart block, cutaneous lupus, hepatobiliary dysfunction, and hematologic abnormalities. The risk of heart block is 1 to 2%, but rises to 15 to 20% if a prior child was affected. SSA and SSB may also appear in undifferentiated connective tissue disease, mixed connective tissue disease, autoimmune hepatitis, and rarely primary biliary cholangitis. When SSA or SSB is positive, watch for photosensitive rashes, Raynaud's phenomenon, vasculitic lesions, interstitial lung disease, leukopenia, cryoglobulinemia, and Zika symptoms. SSA positivity also correlates with neurologic symptoms and may indicate ANA-negative lupus. Comparing SSA has high sensitivity for Sjogren's and moderate sensitivity for lupus. SSB has lower sensitivity but higher specificity when coexistent with SSA. Ro52 is associated with myositis, interstitial lung disease, and systemic sclerosis. Ro60 aligns more with classic lupus features. SSA can be positive even if ANA is negative, especially when ANA is tested by indirect immunofluorescence. For pregnancy, SSA or SSB positive women should have fetal echocardiograms from 16 to 26 weeks. Hydroxychloroquine is often recommended during pregnancy to reduce the risk of neonatal lupus. SSA and SSB are useful for diagnosis and risk stratification, but not for monitoring disease activity. They typically persist even during remission. Here's a quick comparison. SSA targets Ro52 and Ro60. LA. Both are found in Sjogren's, with SSA also common in lupus and neonatal lupus. SSA carries a higher pregnancy risk. Neither antibody is useful for monitoring activity. SSA and SSB antibodies are central to diagnosing and managing autoimmune conditions. They guide decisions in pregnancy and help identify patients at risk for complications. Always interpret them in clinical context. If you found this helpful, like, subscribe, and leave a comment with your questions or topic suggestions. Thanks for watching, and see you in the next one.